All right, we'll go ahead and get started. The goal really for the next hour. Hey, we were just talking about you.
All good things. All good things.
It's how I haven't been able to make this in about a year.
We're going to talk about the OSCE station that you are going to be doing for the vein access as well as nerve block. And so our CA3s in the room have done this station already in our mock OSCEs back in September. And this for the CA1s and 2s in here is really just for you to see what the possibilities are for that station and for me to tell you about what that station looks like. So that when you're on APS looking at ultrasounds that you are paying attention to those things that you should be able to identify. So in terms of vascular cannulation, there's going to be 4 areas that they'll potentially ask you about. And these 4 are the IJ, your vessels in your cubital fossa, your radial artery, and your femoral vessels. Now, for vascular access, what they're going to be asking you is to locate the access point that you're looking for. So if they say an IJ line, you would have to take your ultrasound probe, place it on the neck, get the view that you want for the IJ, and then what's going to happen is the person that is proctoring is going to freeze the image when you say that that's the best picture that you can get. Once the picture's frozen, you put your transducer down and they'll ask you questions. The questions that are asked vary. At the very least, they're going to be anatomical questions. What is this structure? What is this vessel? But it also can be to the point of asking you, where would you put your needle? Where's your entry point? What are you looking for? Those sorts of questions. So that's the vascular access. Pretty straightforward. The nerve blocks are going to be, again, some in the neck. The tap block, from what I've heard so far, nobody has gotten a tap block for a location in their actual OSCE examination up to this point, but that's something that is a possibility to be asked. Femoral, adductor canal, and popliteal blocks. So up to now, the popliteal, the supraclav, and interscalene, those are the blocks that are the most common. The AC is also something that shows up once in a while. And then for vascular access, right now, it's really been the IJ and the femoral vessels. The people that have told me about their exams, they have said that if we do a vascular access in the neck, that they didn't do a peripheral nerve block in the neck as well. So if you get a vascular access in a certain location, you're likely not to get a nerve block in that same location. Any questions about these sites? They're limited, they're straightforward. As long as you know what they are and you can look them up ahead of time, that's really the key. Yeah.
Are these on a mannequin or
No.
like on a speed up?
A real person.
Okay.
So that person's going to be in a gown. They're going to be laying down on a gurney or a bed, and you come into the room, and just like you would any person, you'd introduce yourself. You would listen to whatever directions that you're given. ABA actually has a really nice website that I encourage you all to go to that actually has some video on some of these stations, and this is one of the stations they actually have as video, and that gives you an idea of what to expect. But the challenge of this is that this is 8 minutes long. This is one of the hardest stations to get through in a time aligned. People that struggle at the time always struggle with getting their view. So that's something that as you move forward, you need to think to yourself, how am I going to get my view quickly? That way you can start getting questions asked. Does that make sense? Right. So, yeah.
I must have missed the part. What is this OSCE? And
Good.
I literally was like, oh, this is a station. What are we doing?
That is a great question. So for those of you that are not aware, starting last calendar year, is it last calendar year? No, it was this year, actually. It was last year's graduates. So this calendar year is the first year that as part of the applied examination, which is the old oral board examination, you now have the oral board examination plus OSCE examination components. So these OSCE examinations are
going to be 7 stations, 8 minutes each, with some transition time in between stations. And most of those stations are purely communication stations, giving informed consent, talking to a surgeon who's upset because you want to cancel their case, talking to a patient about a complication associated with your care, things of that nature. But 2 of those stations are going to be actual applied knowledge. One is going to be ultrasound. Another one is going to be TEE. Those are the 2 most common ones. But then they also have a third one, which is a monitors one, where they'll actually throw up on a monitor various vital signs that you have to say, what do you recognize? What is this? What would you do? What's the management? That sort of stuff. So it's actually very involved. And so to prepare you for that, we have these opportunities to go through each of these stations. But then as a CA3, you'll go through mock OSCEs. So our CA3s went through that in September.
Which, by the way, like now, it's like really grateful for that experience. The day of, not so much.
Yeah.
You know, as
It
a,
was horrible.
Nobody likes it the day of.
but like now, I'm like, yeah, this is like great because I'm like, man, know what to expect.
Right. And the idea is that as we build this into the curriculum more and more, by the time you get to be a CA3, it's like you know what to expect, and so it's not as much of a being headed against the wall.
So without further ado, can I have somebody volunteer to be the person getting ultrasounded?
You can ultrasound my neck.
I'm happy for my neck too. I'm talking about femoral access here now.
Oh, like,
You can volunteer yourself.
Too.
So
You do
I will be
my leg,
the first
I'm not
guinea pig. Dr. Vitter's going to Dr. Vitter's going to be the examiner. So let me have my CA3s come sit up closer over here because you're going to be the ones driving the transducer.
So bring this dude with me.
I'll put a knife in you, Dr. Oliva. I think we should do that. I like this.
Yeah?
Now we've got this to work this year, so the ultrasound you should be able to see what they're doing up over here. Let's turn off some of these lights so that you can see that better.
Sir, could you bring back to ultrasound? Like a habit, like just like and then we do this and keep going.
Oh, Janine, did Rob find
You
you?
need to stop at some point. Remember you
No.
I was gonna say something before I left.
Okay, good.
I was looking for. I just wanted to. I don't know what to do. Like, so.
I wonder if it's me. Is it more tasty?
That's how I feel most days too.
I think that's the best that I
It's a relatable feeling.
So I'm choosing the person who asked for that. Now, you lay down. So that's
12 hour on top of 12 hour. And then I have one regular.
Oh.
I always introduce myself when I walk in. That was a big thing.
Hi, I'm Dr. Barney. I'm one of the anesthesiologists. I'll be putting in a central line called intravenous internal jugular catheter, okay?
It's very nice to meet, and I'm gonna wash my hands. That's like a big thing. I'm gonna wash my hands. Hi.
Hey.
Hello, you.
Do you waste 8 minutes, part of your 8 minutes though, with the pleasantries? Would it be better to just go right for it?
Nope, you it's for now.
I think Rob told us we
You
had
have
to
to at least introduce
introduce
yourself, say what you're
ourselves.
Do you have to do like?
I am a doctor. I am performing
No.
a procedure.
There's like other rooms where you have to do consent.
Oh, okay.
Do you have to, like, drape them?
No.
Delay.
Oh my god.
This was
So basically, I'm going to do half this procedure.
all right.
Do the little bits.
I want you to pretend that you don't know that machine, Kristen.
Okay.
If you need changes to gain, to depth, you need to tell them what you want.
Oh, she's not allowed to touch it.
Correct.
Okay.
You are the
What?
owner.
Okay. Oh, you're I'm
So you're
I'm
just-
your examiner.
Okay.
So I'm sorry. I'm allowed to touch the machine.
Yes.
Okay, so, So, okay.
So now I would ask questions now. All right. So can you tell me where the internal jugular vein is?
Yes, so the bigger the bigger collapsible vessel in the center of the screen is the internal jugular.
The cheek point.
Oh, yeah.
I mean, typically what will happen is you'll have like a pointer.
Okay.
That's the carotid artery.
All right. And then where would your entry point be for your catheter that you're placing?
So I would come in superficially here and then enter the vessel from the anterior portion.
Did you verify which was your left and right side on there?
I did before. I didn't do it for you, but I verified that the right side is the left side. I was lateral is the left.
So for you then, this is midline, medial.
Or yes, I'm sorry, medial is on the left. Yeah.
Thyroid, you point that out.
So thyroid should be right here. So
It's hard to tell.
it's kind of difficult to discern.
Some people you can see a large thyroid, so that's something that they could point out.
Okay.
SEM?
SCM is this muscle hooking structure. Oh, sorry.
But everyone's special and needs recognition.
So we're going to do
Okay. So ideally, we would be on a bed where I could tilt the patient. I support you. No one else does.
I noticed.
You're kind of towards the midline of
Can you pull your pants on?
Oh, yeah.
Oh,
Oh, yeah.
I'll find you. I shaved my last. Sorry, guys.
I just too. So I'm just looking to repulse
So part of this is to, you get in a position that you're comfortable with, right?
Yeah.
You move the screen.
Show the overlay.
Yeah.
Oh, don't go too far. So you can put your
Mannequin's
arms in the.
I'll do it right here.
I'm going to go around this way.
But you can't.
Yeah, there's too long.
No, see, he could ultrasound on the left, with the ultrasound machine staying on right.
You want to sit in the chair for that?
Like a cross.
Yeah. All of it.
Yeah. Yeah. You always at the same side over each. You guys have a yeah. I see what you're saying. That looks bad.
Oh, yeah. Yeah.
Alright, so left should be lateral. So we're looking for the substrate artery. Lying adjacent to it should be above the brachial plexus.
So you tell me when you get your perfect view on your face side.
Okay.
Okay.
Alright,
So what are we looking at here?
so this should be a subclavian artery.
Okay. And what is this structure?
That should be the links and divisions of the brachial plexus.
Okay. And what is
That should be the first rib.
leave this kind of gray area over here?
So I think I have a head motion approval again, might see some sliding over.
Okay. If you were to do a brachial super nerve block, where would you put your local anesthetic?
We're taking an angle comfortable low in the plexus and trying to get some spread. Deposit some overlap stuff there.
Which side of the spring is medial?
Medial should be on the right side of the screen. Lateral to the probe. And then once I was confident, I'm just going to spread up in. That would redirect a little bit superiorly here on the cervical superior.
I think you're obliquing your vessels. It's kind of, I think you can optimize that a little bit better. That would be a really challenging block. It can't
Unfreeze it. I agree that picture's not the
Like
best
it's really
picture.
tell if like one is, because I think your artery is here. I think that's your artery. Let's see how nice that is. That's all lateral to the artery. So you should be able to tilt and really sharpen to get that drop off so you can really see where first rib is compared to pleura. But you just want to make sure you get the best picture you can. And you could have me change your gain. You could have me change your
So probably higher gain.
There you go. Picture.
Freeze it when you feel like you've got a good picture.
That's a much better picture. Here you can see the script. Here you see stuff off. That's pleura. This is all of this here. You can see the corner pocket. So you actually describe it. Maybe they would ask you something like, why aren't you turning that corner pocket?
Yeah. So that would be more so to get caught that. Better spread.
Okay. What would that be important for?
So it basically gives you the most reliable block for
So go up to that screen, Julian, and point out for everybody else what you're talking about.
So, kind of when you're on APS with us, what you're looking at is to try and get that subclavian artery in kind of a cross section. Radial plexus is always, never say always, right, but always on the lateral edge. So here you can see it kind of looks like a bundle of grapes, and you can see it kind of starts there, and actually it's pretty widespread, going above the vessel a little bit. So we call this the corner pocket, so kind of right there, and that's typically our target. The reason being, if you can get spread into this area, it's typically within the sheath, you'll get the entire plexus and you avoid the ulnar sparing, which is important since a lot of times we're doing this for hand surgery or for things below the elbow and that C8-T1 distribution. Sometimes you'll get a little kind of acoustic enhancement right below the vessel, but then this kind of white line that extends out there, that's part of the first rib. And you'll often see this step off between the first rib and then pleura. So not only do you want to get into that corner pocket, but this is a good view because you have a backboard, you have rib that you're aiming at as opposed to pleura. So it's an extra margin of safety.
So explain how you got him to get that image.
So when you're doing your superclav, you typically start with your probe right around the clavicle, looking kind of under the clavicle. If you are, depending on your rotation of the probe, sometimes you'll cut the vessel obliquely as opposed to on cross-section, which makes doing the block a lot harder because you have more of an area that you're trying to avoid. So Andy rotated the probe until he was able to see this on cross-section, and then changed his tilt until he was able to highlight the first rib. So it's kind of a dynamic process of small movements.
So twisting motion.
And tilting.
Tilting motion. But you can see how long it took him to get that image, right? That's where the time suck is. So don't spend time explaining what you're looking for. Just find it. Right? Any other comments on that? All right, next one.
So you don't have to explain what you're looking for as you're going.
You don't have to verbalize what you're thinking.
No, you want to get your image because the station is for you to identify where the flows in.
Hello, Sarah.
Get your image fast.
Weirdest interaction ever. Hello, sir. I'm here to do a thing. Uh-oh. Is it Modern Cat?
Your subscription.
He keeps telling me he's going to get me a subscription to Modern Cat, so that's immediately where my...
I think you guys unplugged it again.
Need for your graduation.
Christmas. Good. It was fine. I actually had a pretty easy night on New Year's. We just had this like person thing. It was a sad thing. Oh, no, this guy was on the meth and then wrecked his car and then became a paraplegic. Yeah. And then
That's a good look at. That's pretty good. Yeah.
So
We were like,
what are we working at here?
So that's one of the scalings that would be the anterior scaling,
Okay, and what is this?
be the middle scaling.
And what is this?
I'm catching a little bit of the SCM there.
Okay, and what is this here?
That's part of the inner scaling plexus there, so we're catching the roots 5, 6, and 7.
Okay. If you were going to do an interscaling nerve block, where would you put your local anesthetic?
So my approach is going to be from the lateral aspect of the screen, which is the left side of the screen. I'll have an approach that's going to aim between roughly between 5 and 6, and try to get a spread that will encompass the roots.
Can you point to where that is?
So my first approach would probably be right here, just trying to get right onto the sheath and see if I can't get spread around all 3 roots there.
Okay. And what's the nerve that lives over here?
On top of the anterior scaling, so that's going to be the
Hey, this is Sarah.
This is a really good picture too.
No, that's really nice. That's real nice. That was nice. Real nice.
You can take a look from that.
Well, I kind of believe you.
So,
that was mine.
so it took you a little bit to find your bearings initially, right? You were like, I can't quite tell where I am, and then you found, what were you looking for to find your
I
bearings?
always love to start with the supra clavicular because the vessel is going to show me where my divisions are, and then I can trace those divisions back up and then confirm that that's what I'm actually looking at when I see the anterior and middle scaling. And I do the same thing with my supra claviculars anyways. I start with that view, I trace the divisions up, make sure I'm actually seeing the same chords between anterior and middle, and then go back down. And just confirming in 2 different places that I'm at the level that I want.
Anybody else do it differently? Any recommendations on doing it differently?
That is the correct way to do it. Some people can't go over based on like thyroid cartilage or cartilage, and just go laterally from there. I do it the same way Paul does, mostly for the reason that if you are rushing or you're flustered and you put your probe too medially, you will see a big pulsing vessel with small bundles around it that people have mistaken, and there are many case reports of people blocking this area. That's your carotid. So you're way too far medial. So the way Paul is describing the fact that you can identify this vessel with this bundle of grapes, trace it proximally, and it condenses into this really tight plexus, that's an extra confirmatory measure that you're looking at the right thing. So don't, on the exam, let yourself get worried and
Yeah, I think the point is whatever you're accustomed to doing, do that, because you're going to be fast to say that. When I trained, I actually would just throw it on and look for the inner scaling first, go down and track those nerves that come back up. So I did it the opposite, but it doesn't really matter. The point is however you find it fastest, that's what you want to do.
Yeah.
Okay. Who wants to volunteer to do the popliteal?
I already scanned, so I can do it.
Yeah.
Where do you want
Put
me?
up their legs.
Where do you want me? Also. You want me sitting?
Yes. No, late now. That's late.
I know. I don't know. Which one do you want?
I'm looking at the wrong side. Well, I gotta see this.
I'm just doing it. It tells me.
Keep going.
If you want to switch me.
Alright. I'm sorry, she's not on card yet.
Worst.
No. Okay, go ahead and lay back actually. Or whatever's comfortable. That's okay. Can you stand your leg a little bit more? Okay, perfect. Oh, let me push it out of you. You thought you were. You want to I feel like I need to go deeper. I want you to go. Try to go a little deeper. There's an artery, I think, based off of this mostly. Oh yeah, okay. So that's it, right on top, like center. I can trace it up for when I split, but I'm gonna stay right there. Oh, okay, you can freeze it. This is popliteal nerve. Is that what you're asking me? Popliteal artery.
Okay, so what is this?
Popliteal artery.
And what is this?
Oh, and it's the nerve.
What nerve?
Popliteal nerve. No?
Fine. Sorry.
Oh, okay.
Okay.
Sure.
Which branch of the sciatic nerve would this be?
Oh, one was the PT, one was the perineal. I don't know which one's which.
Okay. If you were doing a popliteal nerve block, where would your entry point be?
And this is that what you're asking me?
So you can ask it in different ways. Where's your entry point at the skin?
Okay.
Where's your entry point on your screen?
Okay. So where would your entry point on the skin be?
So an entry point of skin would be lateral, probably about, depending on where it's at, looks like it's about 1 centimeter deep, so it'd be about 1 centimeter from my probe.
Okay.
Sort of directly in.
And then which way would you be coming in on your screen?
I'd be coming in from the lateral side, which is obviously on the right side.
Right side was lateral.
Yeah.
Okay.
I just like it.
And then where's your target?
Well, if this is the sciatic, I'd actually probably be yeah. Down is like a little bit more, but my target is directly straight up the in itself. Avoiding the artery. Kind of distributing local kind of around the nerve. Beneath it and then above it if it didn't look like it was completely.
So I would go up higher. Okay. So if they're going to ask you about this, you're going to want to at least go up to the junction of the two branches.
So I didn't know if I should be wasting time on that, but I guess
Yeah,
I got to see the twins.
I mean, that's
together.
where you're going to do the block, right?
Yeah, like right after they, right before, right when they marry.
Exactly. So here you can still see what looks like tibial. And
I saw it in my marrow already.
I know, I think right there. Like there they are,
Are you,
right?
are you sure right is lateral?
Yeah.
Yeah. Okay. So your common perineal is going to be coming in from that right there.
Yeah.
Okay.
They just split.
So yeah. Okay. So this is the picture you're going to want to freeze right there.
Okay.
Yeah.
So they're further away from the artery too.
Yeah.
Freeze that.
A little more up his leg. Wait, can you unfreeze that for a second?
Yeah. So like where it looks like Mickey Mouse ears, they're a little closer.
Is everybody seeing that split there?
You see those kind of coming up.
You didn't have to go down here a little bit further?
You just have the tibial on top of the artery. Yeah. So right there, see how they're splitting? So you just want to go right with little proximal. Right. Let's go. And then just put it on the other side of your screen. There you go. So you're going to do
Yep.
So,
Pain, that's okay.
it's only the left. It's only the left
Any questions about that?
So which one's the comment? Karen,
Yeah, which one is
Lateral. So the way I remember it is if you are in candy canes and your legs flap out against the metal, which nerve do you injure? Common perineal. So that's more lateral.
And the way I always remember it is because of neuromonitoring. What are we monitoring? Which nerve are we monitoring down here?
Tibial.
It's on the inside.
Yeah. I don't know, did they ask you about muscles or?
Probably not muscles, they can, but not typically for this one. They will ask muscles for the AC and the neck ones for sure.
Okay. Yeah, I'd say if you can say which is the tibial and common perineal artery, those are major structures for
Yeah.
us.
I mean, any of your blocks or vascular access that have borders that you read about, you should know what those borders are. Would you be okay doing AC?
AC.
Yeah, having them do it. Okay. Brandon, come on up.
For shorts. I just want the.
Yeah.
Oh.
I was about to just squish it everywhere.
This is actually
Wait, what?
No, sorry.
When I saw it, I was 12:30 and I was like, I don't know if she's aware.
I was asleep.
IV access.
So I appreciate that.
Oh. You just find a peripheral IV. This is just a peripheral IV.
Correct.
I thought we were doing like a
So
peripheral
cubital fossa, I misspoke. Cubital fossa is going to be vascular access. It's not going to be any nerves.
All right, so left side is going to be
This is for, I'm sorry, for peripheral IV?
Yes.
Okay.
This is the easiest one.
Yeah, sure.
I think it's the one that you can see.
Is it that one right
No,
here?
no, it's not. It's the one that's not beating, Brendan. Some big.
All right.
Who's it? So use your words when.
All right.
All right.
Okay.
Freeze the picture.
Freeze. So we're gonna go for.
Alright, so what are you looking at here? What is the structure?
It's the. I don't know why my mind is blanking right now, but it's the vein we're looking for our peripheral access. It's the AC energy.
That's not what it's called.
No.
Actually, this is why I wanted to bring it up. Who knows what the name of that vein is?
Cephalic?
No. No.
Is it a basilic?
Yes,
basilic.
So this vein that I watched as he was scanning up and down. This vein is the combination between your cephalic and your
Basilic.
yes. Your B and C, right? So that is the median cubital vein.
Median cubital.
Brennan.
You missed that one, man.
So people have different anatomy for this. So this is something that's highly dependent on what you see for your patient. So let's go ahead and go live on this. I want you to actually find both the lateral and medial aspects of the veins that contribute to that vein that you just.
They're kind of similar, but also. So this is going to be the. This is medial. I know. Yeah, I know. What is that? No, that's the order.
Yeah, because the.
So what we call the vein one we just saw? I'm sorry.
The median cubital vein.
Okay. So I think this is the medial portion.
So follow it up.
Yeah.
Oh, you wouldn't be able to tell. He just has extras.
Yeah.
Collaterals.
Yeah. Here we go.
Shut up.
based on what I see there, he doesn't have a very prominent vein on that side, so look laterally.
Going to probably just trace it, right?
Uh-huh.
So, yeah. So we can, I guess, go pause it here or freeze it there.
Well, I want you to just continue to follow it until you
Keep
find
following down.
No, follow it proximal. So I want you to follow
Proximal, okay, so
yeah,
here as long
up
as
to the
it's
shoulder.
more superficial, it's joining
Okay.
there.
Now let's see where you have the contribution of the other side. Yeah. So it's not very prominent.
So it stays, it almost like stays, no, it's, that's it right there, it stays pretty superficial, it looks like. Right?
So there are some people that have the two on each side. It's a straight connection between the two, which I think is what his anatomy most closely resembles. That's the median cubital vein. If you have, I think in my veins actually, you have a couple of branches that actually they come in and then they spread back out. You have different names for those veins. They probably won't ask you in that particular case. But the big vein that most people have is going to be the median cubital vein. It's the most common name for that vein.
You're just charting your lines. You're like, MCV.
This was MCV, this right here.
There's such MCV.
So there's your lateral portion, that's big right there. Can't really see where your medial portion there goes.
Let's kind of make that one.
How's it looking back there, guys?
It's looking good.
Pretty, you're all like.
We got the map. We got the map out.
I have a vein.
Do you have an MCV?
Oh yeah. CV all
I
the
was
way.
pretty grounded in MCV.
CV for life.
Yeah, it's like a bunch of weird little ones.
Yeah, it's kind of hard to actually do like
across the room.
Yeah.
Usually I have like a pretty prominent phallic, but it's hiding right now.
So there's your lateral portion. That
I have a cephalic on the side. This might break you.
So I think you're most of that last part of the arm. So it's a little more medial. You're going to see a whole different set of veins. So that
trace weird.
Oh, there they go. It's like they heard that I was touching it. You suddenly here.
You boys with weirdly bulging arm.
I do actually.
It's a good thing. Access. Look at that.
I'll be honest, I just cheated. I really wasn't following it. You guys can see it on this.
So you can see that for my veins,
Seriously, yeah, racist.
I just want to know what the thing is.
it has a branch.
Side or my
I think it's a drag.
At some point.
I had to guess.
So is that one by your fingertips, basilic? This must be your basilic. Over here.
Oh, it's from Japanese tattoo. It's like do a full body tattoo. And it's just
What is
V is supposed to be
basilic is medial?
Yes.
whole thing.
Like,
easily like snap till it sleeps down to his feet.
Oh, wow. That's big.
That's gotta be.
Oh, he's looked at my veins many times.
Yeah.
He shows me his 12 gauge all the time.
Save the bikini region, like what?
Oh, is it?
There.
Any questions about your vascular access, peripheral nerve blocks?
So they're only going to ask us about the veins, or will they ask us about surrounding? anatomy as well.
Some surrounding anatomy potentially, but less likely for the vascular access portion. For that, what veins are you looking for? Are you getting the appropriate view? Where's your entry point? That sort of stuff.
So bacillic, cephalic, and then median cutaneous. Cubital. Oh.
This is your cubital fossa.
Cubital, yeah.
The vein that's in the E.
So as you do ultrasounds on people, the habit of trying to get your view quick, right? And then knowing the anatomy that's associated with that. The other thing that I'll comment on that I've noticed for some of the people, depth was not adjusted very much, and especially in some of those neck. You probably could have been a whole lot more shallow on your depth and got a better view.
That probe didn't go any more shallow than that.
Was that the most shallow?
Two is the shallowest, but for the neck and brim was still at 3 or 4.
Yeah. So pay attention to, does it have the appropriate gain for yourself? Is it the appropriate depth? And then find your position, right? So really try to find an optimal view. Any other questions? Let's go ahead and take a break for the CA1s, and everybody else is ready to go.
Yeah, I tried.
That's awesome.
I really responded. I already talked to Dr.
When I wrote that,
Yeah, she was like, I think we talked about this already, but sure.
you have to meet after, and it's like, we think we do, but we don't know. And so
Yeah, I did that. I did. Right.
Hi.
Who dibs on not working tomorrow?
If you need me, I
Yeah,
can
Shelby,
stay to
no.
go
Nice
block.
try.
I'm surprised.
Oh,
Hey, thanks for coming back after we're done. She knew
I
how to get out of the line of fire.
That bilateral.
But I was already there.
Shit talking you. You're in a bad spot.
He didn't even know that he
That's
was getting an amputation.
Well, that's very bad.
That's a surprise.
He had no idea what was going on. And then, yeah, he had no idea. I spent 7 minutes talking to him. He wasn't even saying like real sentences. I just don't know.
Okay, I'll work on.
So maybe he went cold.
I was talking to him in English. He didn't speak English.
Oh, that's a bummer.
Let's have a process maybe at the end of the day.
Just start doing that and increase the APS efficiency.
You have 8 minutes to do the block.
Yeah. Thank you for your help.
Thank you.
Do you think they'll add more blocks as time goes on?
They talked about it. I don't think they'll do so within the next 2 to 3 years. But by the time you get to that point, they might.
I was going to say that helps us none.
Yeah. I don't know if they're going to add a ton more. I think they're really trying to get a sense of, do people know how to handle the ultrasound, right? And you don't need to have these elaborate locations to find blocks or vascular access to do that.
They had a pair of vertebrae that would fail.
Yep.
All right, I ask everybody else to do it on the lecture. I'm going to ask you to do it. Move to the front.
How far front? Is this front enough? Did I pick a good
We've
spot?
got 5 people. We've got 5 chairs. It's beautiful.
Yeah.
Yeah, there we go.
I talk all the time, and so trying to talk more loudly than I need to is not something I enjoy.
Oh, we need more chairs in here. Oh, what do I tell all about that?
Not me. I don't control hospital chairs.
The ones with the
Might be an
springy
old
back.
Yeah, that's why I just-
Yeah,
I
those
just
are the
switched
best
mine.
ones.
Just switch your chair out.
You can sit up straight.
Yeah, I know. I have the
Practice good
posture.
ergonomics.
while you're on ABS.
Do the lean back.
Yeah. I think I'm also just getting fat because of the holidays, so it's like making my back hurt.
I don't think you'd notice that quickly.
I don't
You don't
think
know my body, Julio. You don't know my body.
That's true. That's very true. I'm not gonna pretend I do.
unless your body was like teetering on the precipice.
It's like that one cookie.
Hey, it could work that way. Who are we to say?
So my topic is supposed to be CNS, and of course that's a tremendously huge topic. So I've got several presentations that I've given on certain aspects of CNS, and I'm going to try to be as complete as possible. But usually I do this over 2 lectures, so we'll see how things go. A lot of this is going to be question-answer stuff. So which of the following is most likely true regarding the respiratory control center? Salud. Take a moment to read over that.
Expiratory neurons. Is that excitatory?
Well, these are respiratory control centers, so you have an expiratory and an inspiratory area. Right? Anybody have any thoughts?
B.
See.
C is correct. So why isn't it B?
Because it's actually protons.
Right.
Proton gradient that controls it, not
Yeah.
C2 itself.
And it's also not peripheral, right? Yeah. So, we'll talk a little bit about the different groups that you have. There's 4 groups that you have in the pons and the medulla. You have inspiratory center, expiratory center. Those 2 are going to be in the medulla. And so you may have heard kind of the dorsal group, the ventral group. Those are designating the anatomic locations in the medulla of these places. For the expiratory center, the key for it is that it inhibits something called the apneustic center. Does anybody remember what the apneustic center is? So the apneustic center is one of these 4 groups that are a part of this whole set of nuclei talking to one another. That's in the pons, so it's in a separate part, so a little bit higher up in the brainstem, and that's what initiates inspiration. So as you would imagine, the expiratory center is going to inhibit inhalation or inspiration. So that's how you get this feedback. And then it is vice versa. You have reciprocal neurons that are inhibiting then the expiratory center from the apneustic center. And then the last location is something called the pneumotaxic center. This is something that is also in the pons. You have 2 sets of these groups in the medulla, 2 sets in the pons. And the pneumotaxic center is something that interacts with the apneustic center, inhibiting it. Right? So it's serving the purpose of expiratory cycle. Right? So the apneustic center, inspiratory cycle. You have an inspiratory center, you have an expiratory center, and then you have the pneumotaxic center, which is promoting the expiratory cycle. So 2 and 2. Make sense? As far as the receptors for hydrogen, as you had mentioned, those are going to be centrally, right, in the brainstem. And then the receptors for carbon dioxide that are in the periphery don't affect respiration at all. So when you get changes in respiration, it's all centrally acting receptors. Where are the oxygen sensors? Yeah, so those are peripheral. You don't have central acting oxygen sensors. Which of the following is least likely to be monitored by sensory evoked potentials?
Between A and
C.
C and A. C. Little motor and A.
So, in terms of sensory evoked potentials, any of the pathways that have sensory information, you can get evoked potentials from, right? So cerebellum has no sensory pathways or fibers, and so that's why that's the least likely location. Thalamus is going to have lots of things passing through it, sensory and other types of modalities coming through there. Dorsal columns, why are those?
All sensory.
That's all sensory, right? That's the definition of your dorsal columns. Good. And then what about cranial nerve 8?
That's vestibular senses.
Yeah, still sensory. Yep. So when we in the OR are doing auditory potentials, that's a form of sensory evoked potentials, right? A lot of people don't think of it that way because they don't call it SSEP, but it's still in the same meaning. Good. Which of the following is most likely to be associated with the intermediolateral gray column?
This is taking me back.
To basic stuff, right?
Yeah. I think it's D.
B.
Any other takers? D is correct. So why did you say D?
I just remember that's where the origination of the sympathetic outflow comes from.
Good. So for this column, it's going to have your preganglionic fibers. So that's exactly right. That's where your SNS is going to originate. So in terms of your spinal column or spinal levels, what range do you have that sympathetic group?
T1 to L2.
A little bit further down. So it's T1 to about upper sacral.
Oh.
So it's a little bit bigger of an area. So so that's really all I'll say about that. Any questions about the other options and why they're not correct?
The C is just slightly off on where it is. Just
Correct.
Slightly cephalad.
Right. So what it is, so yes, that is true. And then what would be your parasympathetic area within your spinal column?
It's all sacral.
It's just the opposite.
That's right. It's cranial sacral. Right. It's above and below. So you've got your sympathetic in between. Which of the following is most likely to be associated with the substantia gelatinosa?
I think C.
I think C too.
C is correct. So the substantia gelatinosa, what's key about it? Why is it important?
It has something to do with your proprioceptive and like sensor, like it goes into the dorsal column somewhere. It's like part of it.
So it's part of the sensory pathway. It's for pain.
Pain
So how does it modulate pain?
Doesn't it attempt to decrease, like, so it makes sense now, like, thinking about it, like, it's receiving all the sensory input, going into your dorsal horn, and then it modulates it so you don't get that, like, huge surge, but it's great.
So that's correct. So it's a local modulatory step. The neurons that are in this area are interneurons. The neurons here have a high concentration of opiate receptors. This is why we put opiates into spinals, epidurals, so that you have local modulation of pain transmission further up the cord. Does that make sense?
Is this also where pain windup happens?
Yep. That's right. So this substantia gelatinosa shows up on test time and time again. So you need to know where it is. You need to know why it modulates things, what kind of receptors it has. There's something called the periaqueductal gray which is essentially analogous to the substantia gelatinosa, but it's higher up in the brainstem. And so it's modulating inflammation coming down. So it's a descending pathway, whereas this is an ascending pathway. Which of the following is least likely to be involved with the ocular cardiac reflex? Everybody's fast on that one. Boom. Been doing some reading, I like it. So what's the afferent limb?
The ciliary and on trigeminal.
Trigeminal, right? So good. And then your efferent? Vagus. Good. So those also show up on tests time and time again. The reflex is going to be manifested in what way? What way do we see it?
Bradycardia.
Yeah, and sometimes asystole. You'll see a long pause. In terms of a clinical response or management of that, what do you do when you see that?
Tell the surgeons to stop simulating.
Yeah. When you go over children's and you do eye cases, you will see this. It's profound. You do adults, you might see it on occasion. There's something called tachyphylaxis that you see with this reflex. What does that mean?
It extinguishes after repeated stimulation.
Yeah. So repeated stimulation over time makes that reflex become less and less robust. So that first response that they get almost always is the worst. And then, so you mentioned the ciliary nerve. So it's the ciliary nerve going into the trigeminal, then going to vagus. Any other questions on that? That shows up all the time as well. Which of the following vessels supplies the majority of motor tracts of the spinal cord?
It's like, it's anterior, and I can't remember if it's Adamkowitz is majority, but it's the anterior spinal arteries.
I think it's D, but A is like a corollary.
I think the artery of Adamkowitz supplies the majority of the middle part.
Yeah.
So it's a little bit of a misnomer, and this is why I have this question, is to talk about this. So this helps to supply blood, but yet when it gets to the spinal cord, it's actually called this. So this is a feeder into this.
Okay.
Right. So you have collaterals, of which your artery of Adamkowitz is the major collateral coming off of the thoracic aorta, but you have others as well. So that's always important to know, and this is why, for those of you that have done any aortic cases thus far, why they really worry about covering those takeoffs for those collaterals. So how do they monitor for whether they've done that, whether they have covered those up? How do they figure that out?
Motor potentials?
That's right. So that's why they do MEPs when you're doing, let's say, an EVAR or TVAR, it would be more accurate. That is spanning from, let's say, the subclavian all the way down to the kidney vessels. So those are an early detection on whether or not you're getting appropriate blood flow. Any questions on that? Which of the following vessels primarily supplies the brainstem?
Basilar.
That was quick. Anybody else? No. So yes, that's correct. And what feeds into the basilar artery?
Vertebrals.
Yeah. I think I have a question about the vertebrals later, so I won't ask another question about that. So let's presume that you have an embolic stroke that is affecting the basilar artery. What kind of presentation will that patient have?
Be like a locked-in syndrome.
Yeah, so they can be locked in, they can be unconscious.
Dead.
Correct.
Dead.
Knocks out their
That
respiratory
was my
center.
patient today. That's what they were concerned about.
Is that right?
Yeah.
From which which artery do they usually don't?
They don't.
Yeah, not for that. Posturing is almost always going to be a phenomenon of supratentorial herniation. Which artery do the vertebral arteries arise? Did I hear anybody whisper?
C.
See?
It's C. So a lot of people do think that they come off the carotid, but they come off to the side of the subclavian. So when you're taking care of these patients that are having big thoracic aorta and arch aorta procedures, that's one of the things you want to consider on the side that they're going to be essentially either bypassing or sacrificing the subclavian on that side, is that you have to worry about flow from that side up the vertebral artery. In which artery does the circle of Willis arise?
Internal parotid and posterior community.
C, yeah.
B, obviously. Your vertebrals and your internal parotid. So I had this on here to kind of confuse people. So your circle of Willis is going to be the part where you're at the bottom is your basilar, right? So that's going to feed into your circle of Willis, and then from the other side is going to be your ICs.
Yeah.
Talk a little bit more about this in a second. Into which structure does the transverse sinus directly drain?
Great vein of Galen.
It sounds great, doesn't it?
It does.
So good.
That's great.
A.
Is that
So,
the one back here, right?
yeah, so it's the one at the back as it curves down. So you essentially have your sagittal sinuses going into the straight, going into transverse, sigmoid, into the IJ.
Where's the great vein of Galen?
That's not a part of your sinus system. That's more, it's a separate, it feeds into the sinus. It's not itself a sinus. Which of the following sites is most likely to have an intracranial aneurysm?
E.
So yes, that is correct. By D.
That's where you get your aneurysms. It has like a the bifurcation is just really, really weak there for some reason.
So approximately 2/3, 3/4 of all aneurysms are going to be on what's called the anterior circulation, or the anterior part of the circle of Willis, of which this is part of it, this is part of it. The other one that's not on here that's part of that anterior circulation is your middle cerebral artery. So those three arteries are the culprits in 2/3 to 3/4 of all aneurysms that we see. The contribution of each of those is about the same, with this being slightly higher than middle cerebral and posterior communicating. Any questions on that? Which of the following venous structures most directly drains the inferomedial parietal cortex?
The trotsal sinus.
So again, think of where your parietal is, right? And then think about what's close by. I have to say that the sinus questions very, I think I've seen one question
Why are
on
they
any sort of exam. I'm sorry?
Why are they important to know?
No different than your arterial supply, right?
Okay.
So they view it as understanding the flow of blood to and from the heart.
Okay.
Yeah. Which of the following is least likely to be a component of cerebral cortex?
B. Good.
So limbic system is subcortical structures. The head of the caudate nucleus is contiguous with what structure?
Internal capsule.
So,
That's right.
so this is part of what system?
The
Basal ganglia, good, right? And so I tried to make it such that the other components were not a part of that system, but you have the caudate and the putamen that are opposed to one another, adjacent to one another. Which brainstem structure lies immediately rostral to the spinal cord? What does rostral mean?
That's what I was trying to remember. I think it's medulla.
So medulla, I heard. That's what it is. So again, spinal cord, medulla, pons, midbrain, thalamus. Which structure represents the efferent limb of the gag reflex? So it's actually 10. So the way that this is transmitted, your afferent limb is going to be which one? What's that? So what is D? D is spinal accessory.
No.
Right? Spinal accessory is going to do what?
Shrug.
Traps, right? What's 11?
11 is spinal accessory.
No, 12 is.
12 is hypoglossal.
Hypoglossal. Okay. And then 9.
Glossopharyngeal.
Glossopharyngeal. Right. So which one is going to be your afferent limb?
Glossopharyngeal.
Yeah. So your glossopharyngeal is the afferent limb. That's what's detecting whatever it is. It's stimulating that gag reflex, sends it out, and then the efferent limb is going to be 10. These are some other things that you can see, and we have time for me to open up another PowerPoint to talk about some of this stuff, but things related to anatomy, so caudal space, especially related to like peds, even though you don't do a ton of peds and do caudal blocks, knowing what that anatomy looks like shows up. Motor neuron anatomy, the motor evoked potentials we'll talk about in a little bit. Landmarks of the cervical spine, I think I have that. Pupil innervation, oculocranial nerve innervation, chemoreceptors, other reflexes, and sensory pathways. So these are all things that you can see. I do have a couple of things on cervical spine anatomy that I have written down in here. We talked about this a little bit when we were doing the ultrasound. How do you use external anatomy to correspond then with where you are from a vertebral anatomy? So for instance, your thyroid cartilage, we talked about it briefly. What does that correspond to?
C2, C3.
What's that?
C2, C3.
5, 6.
No, it should be lower because that's where you're below the ribs.
So you're a bit high, you're a bit low, so it's in
C4.
between. So it's about 4 or 5, depending on somebody's neck, right? So just below, when you talk about the cricoid cartilage, that's going to then be around C6, generally speaking, right? C3 is going to be hyoid. So if you think about it, 3, 4, 5, thereabouts 6. So that kind of gives you that space there. If you're feeling posteriorly, which is the first spinous process that you can palpate?
C2.
2.
It is 2. Good. How can you verify the spinous process of C6 with palpation, besides just counting down?
I was going to say go to
I think
7.
C7 is the dominance. So they just went up.
Yeah.
So you can use C7, which is the most prominent in most people. In some people, and I think I actually am one of these people, T1 is more prominent than C7 for me. So C7 or T1 are the two most common ones that are the prominent spice process.
How did you figure that out?
By touching myself, I guess. When I'm learning this stuff, when I'm learning this stuff and I read about it, I'm constantly feeling just like we were doing earlier with our veins, right?
I don't know if you had like imaging of your neck done or something.
No, but when I was a resident, I would be ultrasounding myself all the time and trying to figure out where my stuff is. Where would I go if I was doing the block on me? C6, in most people, the interesting thing with it, if you don't have another way to determine it, is actually when you have the patient extend their neck, it actually goes in. It disappears. So you can palpate it when you're flexed, but then you go ahead and you extend and it goes and retracts. So that's cervical spine anatomy. Oftentimes it shows up again, just like what cervical space are you for thyroid cartilage, hyoid, so just kind of remember those. Pupil innervation, you've got two muscles. You've got your sphincter as well as your dilator. And so these are two different muscle groups that are innervated by either sympathetic or parasympathetic fibers. So your constrictor obviously is going to decrease the size of your pupil. Your dilator obviously is going to increase it. In terms of sympathetic and parasympathetic fibers, which one is going to constrict? Parasympathetic, right? And sympathetic does the opposite. Does anybody know where the parasympathetic fibers come from, which nerve they come from? Good. So it is oculomotor nerve that actually supplies those fibers. All right. You guys want to stand up and walk around for a bit? Take just a short break while I get the other one up and going.
Your western nucleus. Ah, yes. That's a throwback.
Right? The stuff, people are always surprised. They're like, man, I didn't realize they were going to ask this kind of question on my basic exam.
I never took Dr. Hoderman seriously.
I know, right? I feel so betrayed by myself 4 years ago.
You'll be taking it in June.
June? Oh my god, that's so soon.
Yeah, it is right around the corner.
I'm like not ready for this ITE.
Most people aren't, and that's normal. Even people that have been studying a lot say that they're not ready for it. So
I've been too tired to study lately. Actually, most of
I've
the
been
year.
going through a real rough stretch of True Learn.
Oh my god, True Learn just destroys my confidence.
Yeah. Are those questions like unnecessarily hard?
Some
of them are. Some of them are just like, I don't even know what you're asking.
Yeah.
Like, I have no idea what you're getting at.
Or I think they're being too complicated and miss something really obvious.
Enhanced ones where you're like,
Yeah,
What? This one unique piece scenario? Ventilation strategy?
Oh, yeah. Yeah, that's wild. I had one of those. I was like, I know. You pretend to know.
They always ask about back roll.
It just looks like a weird kid.
Yeah.
That's what you said.
Like, they threw up Bacterol, and I was like, come on.
Yeah, back roll is not my favorite. And then my least favorite ones are like the ones that ask about policy or insurance.
So many maintenance of certification questions.
Yeah. It's just like, how many do you have to do, and where do they have to be?
Yeah, I actually did my full year of maintenance of certification questions Christmas week.
It's like one in the first 5 years.
120 questions. It's not very much for us. It's 30 questions per quarter, but I didn't do any all year. It's like the
So you basically took an ITE.
Yeah, exactly.
That's funny.
So see your whole life of doing questions. Yeah, it never ends.
Tell me this, my guy. I quit now.
This is why I tell everybody when they are going into medical school, why interview medical student applicants is because it's like, this is your life. This is a lifestyle. This is more than a career. So we'll talk about some pain neurotransmission, some opiates, and some practice questions again. So it's hard for some of you to see that, I'm sure. I don't know if I can move this at all. But in terms of the cross-section of your spinal cord, so this is really color-coded to be sensory versus motor. I think this is one of the best snapshot images to take for yourself in terms of where things are at in terms of sensory and motor fibers. So dorsal columns, you'll sometimes get questions that will be anatomical location of fibers. So knowing that as you come up the spinal cord, things layer on laterally, right? So medial is always going to be the furthest down. So sacral, lumbar, thoracic, cervical. That is opposite to what you're going to see in this anterolateral system, which is off to the side here. And this is where you get neurons that then are going up ipsilateral or contralateral from when they come into the dorsal horn. Okay, so we're coming to the dorsal horn, have a synaptic transmission there, some modulation that takes place within the neurons, and then they will either go dorsal column immediately or they'll go across and then come back and up. So that's important. The motor tracks, again, descending. So your corticospinal tracks, these are the descending fibers, but then will come in through the anterior horn and then exit out. These other smaller tracks you don't need to know. And then with respect to your sensory system, your dorsal columns, we'll talk about the information that's transmitted there here in just a second. Any questions about the anatomy? I don't remember if I have a picture of it, but in the dorsal columns you have different, what are called lamina. And the lamina are just essentially layers of where you have synapsing taking place of those sensory neurons coming in, and then the interneurons that will modulate those signals. I think it's lamina 4, 5, 6, thereabouts, that the substantia gelatinosa lives. So that's where those neurons are going to be in the dorsal horn. So yeah, we'll focus on the spinothalamic tract and your dorsal columns. So the spinothalamic tract does temperature, pain, and pressure. And the reason why I read it that way is because for me, it's the way I remember a little bit of what that information carries, right? So temperature, pain, and / pressure. So that's why I read it that way. These cross midline almost right away. But the key there is it's most times not right away. It's 1 or 2 levels above where they came in. But the idea is that it's pretty quick. These are A delta fibers and C fibers. So what does A delta fibers mean?
They're myelinated.
Myelinated, bigger, right? Faster transmission. What are unique about C fibers?
Non-myelinated.
Why does that make any difference?
Slower transmission, harder to block.
Slow for transmission. In terms of blocking, so what's the order of fibers being blocked, let's say by local anesthetic that you deposit either in the spinal cord or by a peripheral nerve?
I'm guessing that it's actually faster, based on how you're saying this.
Good.
Because it's the smallest.
The
blocks
smallest and
fibers.
myelinated, I think, are blocked more easily.
So the smaller it is, the faster it is.
Right.
And if it has myelin, it's faster. Why is it faster?
Because you only have to block them as a ground PA.
That's right. And so that's why you actually get, what's the sensation most people get when they start to have the block, whatever it is, start to set up?
Tingling.
Tingling, warmth, right? Those are a couple of the sensations people will comment on. That's why they have that first. C fibers, though, will still be blocked before your A delta fibers in most cases. Your dorsal column, that's going to be proprioception, vibration predominantly. And those fibers cross high, right? So think about those fibers coming into the spinal cord, they go straight up without synapsing, they synapse, but then go straight up those dorsal columns and don't cross over until you have the brainstem. And these are 8 beta fibers. So how do those compare to the 8 delta fibers? Bigger, smaller?
Smaller.
So they're bigger. And they have faster transmission. And this is why, if you think of it in terms of, I won't go into that. Modulators, we talked about the substantia gelatinosa in the brainstem. I told you about the periaqueductal gray. And so this periaqueductal gray does it through this pathway of descending information. And I talked about how opioid receptors are mediating these actions. So opiate pharmacology, you've got different receptors all throughout the central nervous system. These are decoupled protein receptors that inhibit neurotransmission. Potency sometimes comes up on exams, so this is potency relationship. This relationship here sometimes can be argued. So sometimes people will say that these are equipotent, but some other places you might read that Remy is twice as potent as fentanyl. In terms of protein binding, you have sufentanil that's highly protein bound, hydromorphone that's not, everything else in the middle. Lipophilic, sufenta is highly lipophilic, morphine is not. That plays a role when you start thinking about giving it on the neuroaxial basis, right? So if something's highly lipophilic, what does that mean when you inject it? So we give fentanyl sometimes with our epidurals. Why do we do that?
It's absorbed quickly at that level that you inject it.
Right, so it localizes to a much more discrete set of levels versus something like morphine. So why do we give Duramorph to a woman who's having a cesarean section? You get more spread,
lasts longer,
and it lasts longer. So those two in combination. So for a given dose, you have more spread that will cover more dermatomes. Metabolism, they're all hepatic pathways except Remy. And before I get to metabolism, I got a bunch of questions, surprisingly, on my maintenance of certification about this. So they're hepatic pathways, but which pathway have you read about that actually metabolizes most opiates? But what P450 system?
384. No, 2D6.
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 I was just behind the pharmacist.
So it's 2D6 that is going to be the main enzymatic pathway for these agents, except for 2 opiate agents. Does anybody know which 2? All of the other opiates, and even the PO opiates, require that pathway to create the active metabolites. These 2 are already active metabolites.
Oh yeah, morphine is what 2D6 converts codeine to.
That's right. That's why patients that have no response to codeine don't metabolize codeine into the active metabolite, which is going to be morphine.
And then it gets glucuronidinated to M6G. Okay.
Yeah. So the key here, and the reason why I was getting asked this question, the context of the question was, you have a patient that has been genetically tested, and they have a deficiency of this 2D6 pathway. Which of the following medications is appropriate to prescribe this patient or to use for this patient intraoperatively?
Morphine or Dilaudid.
Correct. So that's something that you probably need to know on a little bit more deep level than just that it's hepatic pathways. And then how is Remy metabolized?
Plasma colonoscopy.
Yeah. So, I talk about this a lot when we do neuro cases. REMI can be pretty unpredictable for breakdown patients. It really depends on their liver function. It depends on their genetic background. So we talk about all the time pseudocholinesterase deficiency in patients that we're using sets for, right? Well, the same is going to be true for REMI. You might not notice somebody that took, say, 20 minutes or 30 minutes to recover from SUFs, but you'll know somebody that you turned off REMI an hour ago and then they're still not waking up. And you do see that on occasion. There are more people out there that metabolize REMI slower than you would expect or imagine. So usually it's fast off, but not always.
Trevella from Denver Health told me that if you mix Remy and lactated ringers, it will break down. Is that true? Have you heard that?
I do not know the answer to that.
I've never heard that before either. And he was like, you can't draw off the bag. You have to actually use normal saline, or else it hydrolyzes in the LR.
He was my advisor. He said so. I trust him. And he's probably listening right now too.
He probably is. It's crazy.
Making some sort of comment.
Yeah. I'll look into that then. I'll ask him. You're like, show me a source. Renal excretion for the various metabolites. Meperidine shows up a lot on tests, even though we don't use it very much anymore. So if you see meperidine as an answer on there, and it's kind of a weird question, it probably is the right answer. It causes seizures. It has issues with certain metabolizers.
Breastfeeding.
That's right. Yeah. So it's kind of the oddball. Antagonists, naloxone and naltrexone. Most agonists, antagonists, buprenorphine, most commonly. So let's do this first question. Sufentanil is that is correct. So histamine release is not a problem. Burst suppression, this is a big time to talk about EEG with respect to opiates. What is the impact of opiates on EEG?
Brenda can actually increase it can increase your biz or your SED, which is kind of
So usually it's neutral. Usually it doesn't cause any up or down movement of your EEG. So we think anesthetics largely are slowing effects on EEG. Opiates do not impact it whatsoever. So you're not going to get burst suppression. If you're going to do cases where they're going to say, I need burst suppression or I need isoelectricity, you're not going to be using opiates to do that. Obviously, it's more potent than fentanyl. Redistribution, no. Which one would this be the right answer for? Which opiate would C be the correct answer for?
Fentanyl.
Fentanyl. So fentanyl, if you think about it, fast on, fast off, it's not because you're getting rid of it, it's because it's being redistributed, right? And then histamine is likely to be which opiate? If a patient has taken a MAO inhibitor, which of the following should be avoided?
D.
Boom. Right? And why is that?
Because if it seems like a weird question and it means it choices, it's probably not.
You listen well.
It has some
It's like some dirty drug. So
very
yeah.
dirty drug.
Serotonergic.
That's right. So the key here is, what are you trying to avoid? Serotonin. High doses of fentanyl may cause hypotension as a result of which of those things?
What I've decided is not an answer choice.
Yes.
I hate it when that happens.
C.
D is correct. Why did you pick D?
missed something that I read.
Hey, what's up, Nate?
Got it.
Just finished
It's
up
not,
giving lecture to the
I was
residents.
between, I was like 3 and 4.
Yeah, that's what I was
And-
thinking as well.
Well, that's what I thought you were going to say. Wow. Well, I hope that you'll consider all that I've done for you.
I know, right? It's awful.
So, do we have
Yeah, you can bribe me. That's all right.
I thought they got into like the higher areas, and that's why it wasn't mediated through the GI tract.
Yeah.
It was more like
That's
central.
a central one, the CTC, yeah. Not amnesia, that's for sure. Yeah, I'll check.
Yeah, I did the renewal.
Ew. This is
I think that it is, and that's why I wanted to forward you the information and let you know that this was going on, because I have no
It has
Basically, that's
aspartame in it.
Oh,
All of these do.
yeah.
Ew.
Yeah.
Like all day.
I
Sodas.
hate aspartame. I didn't realize it was a diet soda.
It didn't.
It didn't used to be. It used to be
super sugary.
super sugary, like so bad.
It used to be like
I've
worse
never
than
seen this
Sprite.
thing before.
Yeah.
I didn't know this was a
And notice they've like completely remodeled the can. It's
They did.
very sophisticated now.
But it's like a very
Perfect.
throwback you can.
Yeah. Like a Pellegrino.
Very
And if you need me to send you the actual proof of the submission, I'm happy to send that to you. That way they can see the timestamp and everything. Okay. You're exactly right. You don't know me.
Can't be trusted. Can't be trusted.
Well, good. I hope it keeps you on track. All right, man. Yeah, you're right. All right, man. I'll talk to you later. All right, see. So, see, things happen when the government shuts down. I submitted my DEA renewal, and they're not processing it because this division is shut down.
They're also not processing my student loans, so the government says that I owe them $4,500 a month instead of $300. Yes.
Yeah. Well, my problem, they're talking about taking away my prescribing privileges through Epic, and I'm just like,
What?
guys,
Come
you're
on.
retarded. I submitted my renewal weeks ago. It's not my fault.
Hey,
But
but
your
Trump
taxes be
says that.
processed.
Oh, are they?
They're going to. Yeah, he's going to open up the IRS.
Because Trump was saying this could last for years if he doesn't get that wall.
So that's good.
Years.
Years.
That's what he says.
That's what he's threatening, months to years. Because he's a child. Anyway.
He needs to declare a state of emergency and then it'll go away.
Opioid antagonists produce, opioid agonists produce, which of those things?
4.
D.
Saw the answer.
No, we're just smart.
So,
Why are you laughing?
how does it affect the pupils?
They constrict.
Good. And then, how is it mediated for nausea and vomiting?
Chemoreceptive trigger zone.
Yes, so that's a centrally mediated process, and doesn't do anything for amnesia. Good. In a patient who is physically dependent on morphine, which of the following are symptoms of abstinence syndrome that begin within 12 hours of the last dose?
One and 4.
That's not an option.
I know, it's bothering me. So 4.
That's one.
1 and 3? Can't you get goose pimples?
So the key there is the
12
timing.
hours.
Oh, 12 hours.
Yeah, so that's the key. So you're right, but within the time frame that they're stipulating there, it's going to be 1 and 3.
They yawn on it or something. Something dumb when they're withdrawal.
So by that definition, I'm like withdrawing opioids all the time.
Diarrhea.
Which of the following is not involved in sensory transmission?
E.
What is it? Presented diversity.
How do you read so fast? I'm reading A. I'm really not fast A.
Dorsal root just throw that away.
pattern recognition.
It's test taking strategy.
So what is precentral gyrus?
I have no idea, but I know the other four are involved in it.
So anybody else? What is precentral gyrus? What do you say?
Frontal cortex.
So precentral gyrus. Where's the central gyrus? Central sulcus is what I meant to say.
Behind the precentral gyrus.
So central sulcus is where? Here. See up? So it's essentially right in the middle. You actually have a suture above where it should be.
Oh, is that the association cortex?
So
That's the motor.
Motor.
Oh,
Good. So precentral gyrus, meaning it's in front of your central sulcus, so it's the gyri just anterior to your central sulcus, is premotor cortex. So that's when we do motor evoked potentials, the screws are going over the precentral gyrus, stimulating there, then the signal transduces down. So that's part of the motor pathway. Everything else on there is part of the sensory pathway. Let's see here. We talked about some of those CNS effects of opioids. The eye manifestations are the Edinger-Westphal nucleus. This is something that some people don't appreciate, that even though you didn't change EEG a lot with opiates, you actually still do decrease the metabolic requirement for oxygen, some. So it can be helpful if you're trying to use that as a means to decrease ICP. It's not the best thing to use, but you can. We talked about the CDZ. This biphasic respiratory depression. This is why we have patients that you give morphine to monitored for a day. Is that biphasic aspect. So the initial phase from absorption and then the second phase, which is later. So you need them to be monitored. And that's why if you're going to have a patient, you see this sometimes up on OB, a patient will come in for a cerclage. You don't want to put opiate into their spinal for that cerclage placement because they might have this biphasic response. My computer just died, so that's a good stopping point. Any other questions about things that we've talked about?
Is there a dose, response, or I guess a dose in which the intrathecal morphine doesn't cause that biphasic response?
Well, it's interesting. You'll hear a lot of nursing staff say that they never see it. It's more of a hypothetical possibility. I would say that if we see it, we're going to be more of the patients that you have thoracic epidurals for, that you use morphine as a bolus, which we don't do hardly ever. So that's partly why I don't think we see it very much. The dose, what's interesting about the dose is that when I was in training with same stage you guys are, we would give upwards of 500 mics in a spinal dose and give upwards of 6 milligrams as an epidural dose. We give half of that, maybe a third of that now. I mean, I see sometimes people are getting 100 mics of morphine intrathecally and as little as 3 milligrams, 2 milligrams epidurally. So I think they're appreciating that just because you're getting a higher dose, you don't get more analgesia, you get more side effects. What else?
Bimodal portion only with boluses.
Say one more time.
If you have, is it only with a bolus dose? The theoretical bimodal respiratory depression?
You mean the initial respiratory depression, the systemic absorption?
I guess the second portion.
So that portion is going to be, again, neuriaxial. Yeah, so that's essentially mediated process as opposed to a peripherally mediated process.
And then that's separate from M6G causing its own respiratory depression, right?
Yeah.
Okay.
But for more lipophilic opioids, do you not see that second phase as
Correct.
much? Okay.
Yep. That's right. All right. Well, thank you for your attention.
Thanks.